Okay, why don't we hello, everybody. I think the new people who've come in are Maureen, and I saw Joe Bush somewhere. Joe and Maureen, this is Mina. Mina, this is Maureen and Joe.
Hi.
Hi, Mina.
Hi.
Hello, nice to meet you virtually, Mina.
Hi, nice to meet you too.
Okay, so Mina is a clinical research scientist in the Department of Anesthesiology at Brigham and Women's Hospital at Harvard Medical School. And the presentation that she'll be giving us today is the effects of cognitive behavioral therapy on brain connectivity, supporting catastrophizing in fibromyalgia, a randomized controlled trial.
Thank you so much. Hi, everyone. So today I'm going to present some of my work. I'm a clinical scientist at the Department of Anesthesiology at Brigham and Women's Hospital, and I study the psychological factors that affect chronic pain. So I'm going to start to talk a little bit on how psychological factors affect chronic pain. In 1965, there was a theory that was proposed, which is called the gate pain control theory. And it basically suggests that there are some special neurons in our spinal cord where the pain signal travels through. And there are different behaviors that we can do that can open those gates. Those special neurons are conceptualized as gates. And there are two that can close the gate. So when the gate is open, we feel more pain. When the gate is closed, we feel less pain. So some examples that can open the gate include emotional factors such as anxiety, depression, negative thinking. If you concentrate on the pain, you're going to have more pain. Some behaviors that can close the gate include being in a good mood, trying to distract yourself away from the pain, concentrating on other things. This would help close the gate. So you can think of this theory and you can think about athletes, for example, that sometimes they get injured, but they don't feel any pain until the race or the game is over. That's because they're very concentrated on their aim. So I would like to show you a short clip that explains how this pain gate control theory works and how those different psychological factors affect chronic pain. One of the things that I would like to highlight is that chronic pain is a very individual experience. It's very, very subjective. It's based on self-report. And all those psychological factors can affect this pain experience. So we're going to watch this short clip, and then we're going to continue with some of my research.
Let's say that it would take you 10 minutes to solve this puzzle. How long would it take if you received constant electric shocks to your hands? Longer, right? Because the pain would distract you from the task. Well, maybe not. It depends on how you handle pain. Some people are distracted by pain. It takes them longer to complete a task, and they do it less well. Other people use tasks to distract themselves from pain, and those people actually do the task faster and better when they're in pain than when
I missed the audio. I don't know if I'm the only one.
No, I missed it too.
I cannot hear anything.
Yeah, I think maybe because she muted herself.
Oh, yeah, Mina, you muted yourself. So
Or she's muted. If somebody can unmute her.
I'm going to try. Okay.
where is she now?
Oh, can you hear me now?
Yes.
sensory and emotional experience associated with actual or potential tissue damage.
Do you want me to start the video from the beginning, or you've heard the first part?
Is there a video that goes with this, or is it just the audio?
Oh, it's a video too.
Okay, because we're not getting the video. It's just the audio and you.
Oh, I'm getting the video.
We're
getting the video.
we just missed like one small part, but I mean, you can restart it if it's not long.
Yeah, it's not very long.
Yeah, just restart it.
Okay, thank you.
Let's say that it would take you 10 minutes to solve this puzzle. How long would it take if you received constant electric shocks to your hands? Longer, right? Because the pain would distract you from the task. Well, maybe not. It depends on how you handle pain. Some people are distracted by pain. It takes them longer to complete a task, and they do it less well. Other people use tasks to distract themselves from pain, and those people actually do the task faster and better when they're in pain than when they're not. Some people can just send their mind a wandering to distract themselves from pain. How can different people be subjected to the exact same painful stimulus and yet experience the pain so differently? And why does this matter? First of all, what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is something we experience, so it's best measured by what you say it is. Pain has an intensity. You can describe it on a scale from 0, no pain, to 10, the most pain imaginable. But pain also has a character, like sharp, dull, burning, or aching. What exactly creates these perceptions of pain? Well, when you get hurt, special tissue damage sensing nerve cells called nociceptors fire, and spinal cord, and then up to the brain. Processing work gets done by cells called neurons and glia. This is your gray matter. And brain superhighways carry information as electrical impulses from one area to another. This is your white matter. The superhighway that carries pain information from the spinal cord to the brain is our sensing pathway that ends in the cortex, the part of the brain that decides what to do with the pain signal. Another system of interconnected brain cells called the salience network decides what to pay attention to. Since pain can have serious consequences, the pain signal immediately activates the salience network. Now you're paying attention. The brain also responds to the pain and has to cope with these pain signals. So motor pathways are activated to take your hand off a hot stove, for example. But modulation networks are also activated that deliver endorphins and enkephalins, chemicals released when you're in pain or during extreme exercise, creating the runner's high. These chemical systems help regulate and reduce pain. All these networks and pathways work together to create your pain experience, to prevent further tissue damage, and help you to cope with pain. This system is similar for everyone, but the sensitivity and efficacy of these brain circuits determines how much you feel and cope with pain. This is why some people have greater pain than others, and why some develop chronic pain that does not respond to treatment, while others respond well. Variability in pain sensitivities is not so different than all kinds of variability in responses to other stimuli. Like how some people love roller coasters, but other people suffer from terrible motion sickness. Why does it matter that there is variability in our pain brain circuits? Well, there are many treatments for pain, targeting different systems. For mild pain, non-prescription medications can act on cells where the pain signals start. Other stronger pain medicines and anesthetics work by reducing the activity in pain sensing circuits, or boosting our coping system, or endorphins. Some people can cope with pain using methods that involve distraction, relaxation, meditation, yoga, or strategies that can be taught, like cognitive behavioral therapy.
I'm just gonna stop here. Oops. So one of the constructs that I have been studying for the past 5 years is called pain catastrophizing. Pain catastrophizing refers to the set of negative cognitions, emotions, attitudes, and beliefs about pain. It can both be a trait and a state, and it has 3 dimensions. The first dimension is magnification. The second dimension is rumination, and the third dimension is helplessness. So in 1995, Sullivan at the University of McGill developed a scale to measure pain catastrophizing. Those negative ones on pain. So some examples include, I worry all the time about whether the pain will end. I feel I can't stand the pain anymore. I wonder whether something serious may happen. So people that have chronic pain, a lot of times have a lot of negative thinking about the future. They have a lot of worry thoughts on how their pain is going to be, especially if they have a bad day. So a lot of times they tend to think in a negative way about how their day is going to be, how the future is going to be. A lot of times they ruminate, they think about the past and how their lives used to be, how they were able to be functional. And it's very difficult to stay functional and do the things that they want to do. So that's one of the constructs that has been associated with chronic pain. So in 2016, we published some pilot findings from a study that explored the effects of cognitive behavioral therapy on brain connectivity, as well as catastrophizing in fibromyalgia patients. And we're now running a big clinical trial looking at the effects on cognitive behavioral therapy on the brain, as well as catastrophizing. So fibromyalgia, maybe some of you are familiar with fibromyalgia. But fibromyalgia is a widespread pain condition, and it also includes a lot of psychological symptoms, such as depression, anxiety, fatigue, low energy, sleep disturbance, as well as problems with and attention, which we call the fibrofog. So one of the therapies that has been shown to be very effective is cognitive behavioral therapy. And the reason for that is that cognitive behavioral therapy helps reduce pain catastrophizing. Cognitive behavioral therapy helps reduce this negative thinking that people with chronic pain have, and as a result, this can affect chronic pain and reduce pain intensity. So the aim of this study, and those are only the pilot findings, but in this study we aimed to assess the effects of cognitive behavioral therapy on brain connectivity and pain, as well as how cognitive behavioral therapy can help reduce this pain catastrophizing, this negative thinking about pain, and how by reducing pain catastrophizing, this can affect pain intensity in people with fibromyalgia. So at the bottom, you see the research design. People came in for an MRI. They did some psychological testing. We gave them some questionnaires on depression, anxiety. We also did some sensory testing. So we basically induced pain in people, and then we collected their self-report pain to measure the pain variability. And then the fibromyalgia patients were randomized into the cognitive behavioral therapy group and psychoeducation. In the cognitive behavioral group, people learned how to reframe their thinking, reduce their catastrophizing. They learned skills how to balance their thinking, not necessarily make it positive, but try to find the evidence for, the evidence against, as well as learn some behavioral activation skills that could help them pace themselves better. In the psychoeducation group, which was the control group, people learned about health behaviors that can help them manage the pain better. And then after they finished the intervention, which was 4 weeks, they repeated the same MRI, and then they did some psychological testing. I would give them some questionnaires again, the same questionnaires on anxiety, depression, sleep, cognitive skills. And we also had a 6-month follow-up. So that was the research design, and those were the results. So those are the behavioral results. We did find that cognitive behavioral therapy helps reduce catastrophizing, so negative thinking about the pain, as well as reduce pain interference. Pain interference is different from pain intensity. Pain interference refers to how much pain interferes with your everyday life. So sometimes the pain intensity might be very high, but people may be able to do things that they want. But it can be the opposite too. Sometimes the pain intensity might be lower, but people might not be able to do the things that they used to. So cognitive behavioral therapy seems to be effective in reducing both this negative thinking as well as pain interference at 4 weeks. And it seems that that was not the case for the psychoeducation group, which was the control group. The fMRI results demonstrated that cognitive behavioral therapy reduced resting state connectivity between the primary somatosensory cortex and the insula, which are both brain regions you see this picture on the left that are related to the pain experience. And this reduced resting state connectivity in these regions was correlated with changes in pain catastrophizing, which is the PCS, pain catastrophizing scale. And it seems that that was the case only in the cognitive behavioral therapy group, not the psychoeducation group. So this is an indication that cognitive behavioral therapy is effective in normalizing brain connectivity in patients with fibromyalgia. So it seems it's a very effective therapy for reducing this catastrophizing and reducing this brain connectivity in those brain regions associated with the pain experience. That's a different study we published a year ago. So we divided people that had low back pain into high catastrophizers and low catastrophizers. We basically gave them the PCS scale, the pain catastrophizing scale, and we divided them into 2 groups. And one of the things that we found was that people that are high catastrophizers, and you see that in this column here, have a higher anxiety, they have higher depression, and they're more likely to abuse their opioid medication. So it seems that catastrophizing is not only a predictor of chronic pain, but also a predictor of substance abuse in people that are prescribed opioids. This study was just got accepted 2 days ago. And in this study, we explored how catastrophizing affects chronic pain in people that have osteoarthritis. And one of the very interesting things we found was that catastrophizing, this negative thinking about pain, moderates the relationship between physical activity and pain intensity. So pain intensity and physical activity was measured by using diaries for 7 days at baseline. So in other words, it seems that people that are high catastrophizers are more likely to experience more pain and exercise less compared to people that are low catastrophizers. So it seems that catastrophizing is a predictor not only of chronic pain, but also of inactivity, so making people more inactive, which is not helpful for chronic pain, as we all know. So those are some of the sensory testing devices we use. So I mentioned before, we do some sensory testing. So we try to assess pain in an objective way. So in the first picture, you can see an algometer where we apply pressure on the trapezius usually, as well as other muscles. And then we ask people for a pain self-report assessment. And then in the second picture, this is the cold pressure device where we induce a cold, we induce pain through cold. We also have a pressure device, a cuff pressure device that you see on the right hand corner. And then we have the bone free that is at the bottom on your left, and then a heating and cold device. So this is more of a standardized measure. It's a standardized way to measure pain. So we basically induce pain, the same intensity of pain in different people, and then we ask for a pain, a self-report pain from people to measure this pain variability. And then we try to correlate these objective measures with psychological measures, such as anxiety, depression, negative thinking, such as catastrophizing, sleep disturbance, etc. So the question is, how can we reduce catastrophizing? So catastrophizing, we know that it's a predictor for chronic pain, substance abuse, depression, anxiety, all these negative consequences. But how can we reduce this negative thinking in regards with pain? And the answer is we can do that with cognitive behavioral therapy. Cognitive behavioral therapy suggests that there is a close connection between thoughts, behaviors, and feelings. People that have chronic pain a lot of times have a lot of negative thinking about the future. They worry that the pain is going to get worse, like you've seen in the pain catastrophizing scale, or they ruminate, they think about how their lives used to be in the past and how they're different now, and they're not able to be functional. And a lot of times these can affect behaviors, so cause a lot of inactivity, also make them engage in unhealthy behaviors such as alcohol use, substance use, eating unhealthy, and this as a result can lead to negative feelings like anxiety, sadness, fear that the pain is going to get worse. So we can break this cycle by intervening in thoughts or behaviors. We teach individuals how to reframe their thinking, how to balance out their negative thinking, and how they can pace themselves, how they can increase healthy behaviors such as physical exercise, eating healthy, as well as pace. Pacing is very important as a skill because a lot of people with chronic pain tend to overdo it. So let's say there is a good day pain-wise, that they tend to do everything at once. So pacing in terms of behaviors can be a very important skill for those people. And those are just a few examples on skills that we teach people with chronic pain. So cognitive behavioral therapy is a directive, action-oriented approach that teaches patients to explore, identify, and analyze dysfunctional patterns of thinking and behaving in relation to pain. So cognitive behavioral therapy helps modify those irrational and negative thoughts about pain, as well as reduce catastrophizing. And this, as a result, affects chronic pain. It helps reduce the actual experience of pain. Mindfulness is another very effective treatment, and we run a lot of interventions and a lot of studies that use mindfulness as an intervention. People that have chronic pain think a lot about the past. They ruminate, they think about how their lives used to be in the past and how now they're not functional, or they think about the future. They worry. They worry that the pain is going to get worse. They're not going to be able to be functional. They're not going to be able to make it through the day. So it's very, very difficult to be in the present. Those people have a hard time being in the present. So mindfulness is defined as the awareness that comes from paying attention on purpose in the present moment without judgment. People that have chronic pain are very much self-judgmental. A lot of times they have thoughts such as, for example, that they did something that made their pain worse, if their life could have been different to prevent the pain. So a lot of times there's a lot of judgment. So mindfulness helps bring this acceptance about pain and help them continue living a valued life despite the pain, despite the worries, that a lot of times can be a detour from living a valued life. So what I would like to ask you to do, and can you all hear me?
Yes.
Yes. Yes, we can.
Okay,
Thank
just
you.
for a minute, if you feel comfortable, I would like to ask you to close your eyes for a moment. If you feel comfortable doing so, and just take a few breaths in and out. Just notice your breath for a minute. without controlling your breath, just notice if it's slow or fast, if it's deep or shallow. Try to listen to your breath. You'll realize that your breath has a very, very subtle sound that it's only you that you can hear. And then bring your awareness to your thoughts. And notice any thoughts that you're having right now. But try to be the observer. Try to notice the thoughts that are passing behind your closed eyes. And try to detach from them and be the observer. Try to do that without judgment, even if they're positive or negative thoughts. Just watch them passing behind your closed eyes. And now stop this effort, and when you're ready, you may open your eyes. You may open your eyes when you're ready. So in mindfulness, and that was just an example, a very short practice, but in mindfulness, we're not trying to stop the thinking or empty the mind. In mindfulness, we're trying to be aware that our mind is wandering and bring it back. And try to do that without judgment, irrespective of whether the thoughts are negative or positive. So the aim in mindfulness is to bring the attention back, bring the awareness back in the present moment. Because most of the times we're in the autopilot. We either think about the future or we think about the past. And this is the only time that we're alive. However, we spend very little of our time. So if our attention wanders 100 times, we simply try to bring it back 100 times. And that's the aim of mindfulness and most of the mindfulness practices. So in mindfulness, emotions are packages of body sensations, feelings, and related thoughts. So thoughts are connected with feelings and sensations. So just to give you an example that is related to pain, if it's a bad day pain-wise, a lot of people have negative thoughts about pain. So one example would include, oh my God, it's going to be a bad day. I'm not going to be able to get through my day. The pain is going to get worse. I'm not going to be able to get to my appointments. I'm not going to be able to do the things that I enjoy. So those are just examples of negative thinking about pain that some people with chronic pain have. And this can lead to negative feelings, such as anxiety, sadness, fear that the pain is going to get worse. And this can aggravate the pain, which is the sensation, make the muscles tense, and as a result, make people feel more pain. So mindfulness helps become aware of how we relate to whatever is arising. A lot of times people that have chronic pain identify with their pain, but their pain is not them. So those practices help detach from the experience, the actual experience of pain. And it also helps them learn how to recognize their reactions to unpleasant experience. So in summary, mindfulness helps switch out of the autopilot, avoidance, and this is a very common behavior in people that have pain. Thinking about, judging, and fixing, reactivity, unhealthy behaviors to awareness, adopt a curious mind and acceptance of the pain, focus on the things that they can do rather than the things that they cannot do. Skillful responding, and taking care of themselves and staying well. Thank you. Understand whether anyone had any questions throughout my talk. I couldn't see any. I'm sorry.
Hey, can you hear me?
Yes, I can.
Mina, I'll show you. I was in Saturday clothes. That's why I'm not showing myself. I've been to the gym this morning thinking about taking care of myself. But I was, first of all, excited to hear your talk and see your bio. I'm in health psychology too, and I'm CBT, and I loved your presentation and your work. One question I had about your study, the fMRI study, is was there any attempt, either experimentally or statistically, to measure the effects of medications or SSRIs that fibromyalgia patients may be taking, not just the pain relievers, but the ones that may affect the same pathways as catastrophizing and such may affect?
Yeah, so we did use that as a covariate.
Okay.
We did use the medications as a covariate when we ran the different statistical tests. Because yes, that's a very good question, because a lot of times medications can affect pain intensity, but it is my clinical experience that a lot of times medications don't work for fibromyalgia patients. And based on my clinical experience, probably 50% of the people do take medications like antidepressants, anticonvulsants like Lyrica, or anti-inflammatory medications, but 50% of those people do not take them. And a lot of the people we get are the people that are trying, they're trying to find answers, and they're trying to find non-pharmacological remedies. So those people that are interested in CBT are usually the people that medications didn't work well for them.
So in your studies, are you getting people who are self-choosing to do CBT?
Yes, correct.
Okay. And then the last question I'm going to ask is, since you kind of mentioned fibromyalgia, is there something you think specific about the diagnosis of fibromyalgia versus other chronic pain conditions that makes them more amenable to CBT?
Yes, that's a great question. And I can talk a lot about my clinical experience because I've seen a lot of different chronic pain populations, but I think in fibromyalgia, it's a very complex condition, I think, because apart from the chronic pain, the widespread pain that people feel, they also experience a lot of psychological symptoms.
Yes.
Such as anxiety, depression, fibrofog, cognitive problems, sleep disturbance. Not all of them, but a lot of people also have a lot of catastrophizing thoughts. They have a lot of negative thoughts about pain. They're very inactive. And our research studies demonstrate that people usually that score high on catastrophizing are the ones that are going to benefit more from cognitive behavioral therapy.
Okay. Thank you. I really enjoyed your presentation.
Thank you.
Thank you. Oh.
Hi. Oh, why are we? Hang on.
Oh, can you hear me, Mina?
Yes. No.
Yes, well, Margaret fixes her audio. Very interesting presentation, similar to Connie. I really enjoy it because my background is on fMRI, is also in addictions, of course, of all sorts of substances. So you talked about catastrophizing. Were you, when you were conceptualizing catastrophizing, were you just focusing on pain catastrophizing or just catastrophizing as a whole?
Oh, that's a very good question. So that was specific to pain. So we used the pain catastrophizing scale, and this scale was developed specifically for chronic pain.
All right.
But catastrophizing can be also a construct that can be measured in healthy individuals, and we do that. We do enroll people that are healthy, and we do ask them about their catastrophizing thoughts. But in this study, we measured pain catastrophizing. So it was catastrophizing in relation to pain.
And so you were talking about how, you know, with cognitive behavioral therapy, which is another thing that I'm very interested in, they were able to kind of like experience a lesser pain experience, right? Did you found any correlation with their substance use or with their medication misuse?
We didn't measure substance use because that was not one of the primary outcomes. But now we are running a big clinical trial, so we're basically continuing this line of research, and we're going to be running some analysis on that because that's very interesting. But one of the things that we have demonstrated in the past, and I talked a little bit about a study that we published a year ago, it seems that catastrophizing is a predictor of substance abuse.
Right, and I was just wondering if they were not only benefiting cognitively about a new outlook in their pain, but also actually reducing their medication. Now, in your experience, like what percentage of patients would you say do benefit with CBT intervention? And that's my last question.
So I think based on my experience, I think 70% of people, and that's my clinical experience, because I do see those people, I deliver the therapy. This big clinical trial that we're doing now. But what we're trying to do is we're trying to tailor the treatment to individual needs.
Yeah.
So for example, some people might have a lot of catastrophizing thoughts. So I focus more on the reframing, restructuring those thoughts, so those type of skills. Other people have a hard time with behaviors. They're very inactive, they stay at home. So with those people, I might work on behavioral activation or pacing. So a lot of times we try to tailor the treatment to individual needs. It's individual therapy treatment, but it is the case that I think 70% of the people do say that they do get benefit.
All right. Excellent. Thank you, Mina. Appreciate that.
Hi, this is Mimi. I had a question about whether or not, so if you were to come to Fielding, we have a number of research labs, we call them research practica, that students are involved with. They have a requirement to participate in a research lab. And I was wondering, would there be room for student involvement in your research if you were at Fielding?
Yeah, sure. And so I've taught in many colleges in the past, and I had a lot of students involved in my research. So now sometimes it could complete an internship, or some of them sometimes are involved in data analysis, publications. So there's definitely a lot of room. And I've done this in the past. But a lot of times it depends on what are the students' interests. But as of right now, we are running 2 clinical trials. So we have a lot of data that need to be analyzed. And we just started a mindfulness intervention for people that are using opioids for low back pain. So in this intervention, we're looking at whether mindfulness can help can prevent people from abusing their medication. So I feel like there are a lot of different domains that students can get involved, and I've done this in the past, and it has been great.
And thank you. Oh, and I wanted to congratulate you on your publication that just got accepted. So if I understand you correctly, it sounds like you have a lot of data, and it might be possible for students who might be able to join you remotely. So for example, not physically come to the lab. Is that correct?
Yes, that's correct. So yeah, data analysis, data collection is not going to be possible remotely, but data analysis, involvement in publications, as well as posters. We do go to conferences, we do present our work a lot of times. So that's definitely a possibility for students.
Well, thank you so much. And I enjoyed your presentation.
Thanks. Hi.
This is Kenneth. I have a question. So on your sample, you said that they were randomly divided into CBT and education. When you ran the demographics or any other analysis on the two groups separately, were there any differences between the two?
Yes, that's a great question. So we do use the demographs as a covariate just to see if there is any effect of demographs. And based on the past literature, it seems that race sometimes or ethnicity sometimes can have an effect. So it seems that that was not the case. It was not a predictor in this study. But that's an excellent question.
Okay, and so you looked for race. Are there other covariates such as, like, did you look at age, socioeconomic status, and some of those things? And so the two groups were the same?
Yes, so when we randomize people, we usually try to match for age as well as demographic factors. So those people were randomly assigned to the two groups. But we also looked at whether those demographic factors affect the reductions in pain interference as well as catastrophizing, and it seems that that was not the case for this specific study.
Great, thank you so much.
Yeah, thank you.
Mina, I would like to follow up on that question. This is Maureen Lassen. When you did the demographics, did you look at whether or not people who were single or divorced did better, or widowed, like single versus people living together with someone else?
I'm not sure that we looked at that. We did look at education. We did look at race, ethnicity, but I'm not sure we looked at this specific demographic.
Well, what did you find out about education? Was that a difference?
No, there was no difference.
Okay, thank you. Thank you. Very interesting presentation.
Thank you.
Who else has a question?
So I'm wondering if I can stop the share because I can't see the, let me see if I can stop the share. Oh, now I can see everyone.
Yes.
I guess I have another question. This is not on your presentation. It's more in terms of areas of interest for you in terms of teaching, and also what kind of familiarity you have with like a distance learning program like ours, which combines both face-to-face interactions as well as online activities.
Yeah, so I've done this before at Lesley University. So Lesley University has a lot of accelerated programs. So what I've done in the past, I've done a lot of like in-person teaching, but also online teaching. I'm very familiar with platforms like Canvas or Moodle. I've used those many times, and I try a lot of times to just upload all the material online because I found that it's just easier for students and it helps with communication. I'm very good with technology. A lot of times I do include a lot of discussions online for students, either group discussions or having students post their comments. So I feel like it would not be a problem because I've done it many times.
Well, that's good to know because actually we utilize Moodle, so that's good that you're familiar with it.
Yeah. Yeah, I think the technology helps because a lot of times, like now, a lot of students do have like apps on their phone, so they can check all the course material. They can check for updates. So I found that even for in-person teaching, the traditional teaching that I do, that has been helpful for everyone.
Thank you.
Can you also speak to the courses that you're comfortable teaching? I know not everybody on here has heard that information yet.
Sure. I feel like any course that it's related to research methods, stats, any clinical course like cognitive behavioral therapy, assessment, mindfulness-based therapies. I've taught many times before biopsychology. I feel very comfortable teaching biopsychology as well. So those are the areas that I feel more comfortable teaching. Does this answer your question?
Yes, thank you.
Any other questions for Mina?
I guess this is a random question, but Mina, would you stay living where you're living right now? Are you planning on moving somewhere else?
So I'm not planning on moving as of right now, but you never know.
Okay. Yeah, it's nice to have some flexibility. I was just thinking because, we have been kind of like discussing ways in which we can enhance our cluster meetings and kind of make them more attractive to grad students. And, it would be great to have you give, a presentation of your work. But we can talk about that in the future. Thank you.
Sure.
Okay, Mina is off to Europe on the 8th, where she'll spend a number of weeks, and then she's going to Greece to be married in a big family Greek wedding with about 200 people.
Yes, that's right. How did you know the number? I didn't share the number with you, but it's 200.
Congratulations.
Thank you. I'm very excited.
Okay, anything else before we say goodbye for now? Okay, thank you, Mina.
Thank you.
Thank you, everybody.
Thank you very much.
And we'll be getting back to you soon, Mina.
Thank you.
Thank you, Mina.
Thank you.
Thank you. Have a great day, everyone.
Nice meeting you. Bye-bye.
Thank you, Mina.